Dr. Adi and Bu Eli.
Terima kasih Dokter Sri. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi buat Bu Eli yang ada di UK and selamat siang buat sejawat sekalian yang ada di sini. So today we will have a very interesting lecture from Associate Professor Elisabeth Schröder-Butterfill. So Bu Ellie is from the University of Southampton, UK. Since 2022, she is the associate professor in gerontology and head of the department. And her research is all about geriatry, and she's been into gerontology since 1995. And then she already published a lot of publications regarding gerontology since 2004. That is my second year of medical school, Bu Eli, and you already published a lot. And then it is very lucky for us because Bu Eli is the co-convener of the British Society of Gerontology and in the Special Interest Group of Aging in Africa, Asia, and Latin America. I guess Bu Eli already uh, very involved in the aging population in Asia, so as well as in Indonesia, also Bu Eli. And so, without further ado, I will give the time to Bu Eli.
Thank you so much. It's a real pleasure for me to be able to join you today. Malang is a place that is particularly special in my heart. So I love Indonesia a lot, but Malang feels to me like my hometown because that is where I did most of my fieldwork in Pakisaji, Malang, starting in 1999. And I'll talk a little bit more about my research in the second lecture today. In the first lecture, I want to focus more generally on qualitative research and how we can use qualitative research to hear the voices, listen to the voices of older people. So let me share my screen. So can you see my screen clearly?
Crystal clear.
Marvelous. Let me just make this a bit smaller. Good. The title of my first lecture is Qualitative Approaches in Gerontology, Listening to the Voices of Older Adults. Let me just try and get rid of that top bar. That's kind of go away. There, now it's going away. So I want to talk briefly about the characteristics and the strengths of qualitative research, and why it's particularly valuable for gerontology or gerontological research or research more generally about older people. Then I'll briefly give an overview of different approaches within qualitative research, but then take a closer look at in-depth interviews and participant observation, and using a couple of examples from published research, not on Indonesia, but on Ireland and America. So what is qualitative research? And I think this quote captures this really quite well. Qualitative researchers tend to be concerned with meaning. They're interested in how people make sense of the world and how they experience events. They aim to understand what it is like to experience particular conditions, for example, what it means and how it feels to live with chronic illness, and how people manage certain situations. So, for example, how they negotiate family life. The objective of qualitative research is to describe and explain events and experiences, but not to predict. So that's one of the ways in which it's sort of different from quantitative research. We don't try and understand kind of causal mechanisms in the world that we can then use to predict. We're more interested in understanding what something means, what is it like, what it's like to experience something, and how people kind of understand themselves and their place in the world. So here are some of the key characteristics of qualitative research. So qualitative research is always very much interested in gaining the perspectives and the voices of the participants. And I'll say a bit more about that in a minute. Rather than getting lots and lots and lots of data from lots of people, so rather than aiming for large sample sizes, instead, qualitative researchers tried to generate rich, detailed data. So sometimes the term thick description is used. It's a term that the anthropologist Clifford Geertz introduced, to kind of capture the kind of detail and richness of the data that qualitative research can generate. Another important aspect in qualitative research is that it tries to be sensitive to the context within which the phenomenon is situated. So rather than trying to control for certain contextual factors, the qualitative research tends to have that really center stage in the research. There's typically a certain flexibility in the research design, and I'll show that a bit more when I talk about interviews and interview guides. There's an emphasis on reflexivity, and by that I mean that the researcher, because the researcher is kind of very much in the moment of the data collection, the researcher is interacting with people when they interview them or observe them, and therefore the position of the researcher has an influence on the whole experience of doing the research. And this means that researchers have to be reflexive about kind of how am I influencing this research situation? What's my role as the researcher? I can't just sort of take myself out of that situation. Qualitative research typically uses small sample sizes. Sometimes students ask me kind of, well, what small or how big? And I always say there isn't a right or wrong answer about it. In one of the studies that I talk about later, the sample size was, I think, only six participants, but very, very rich and detailed data. But of course, you can also have qualitative research with larger sample sizes, and some of my work in Indonesia certainly had larger sample sizes. But rather than trying to randomly select your participants, you usually use something called purposive or theoretical sampling. So you sort of have clear ideas about, okay, I want some people who have these characteristics and some people who have these characteristics, so that I can understand the kind of phenomenon that I'm interested in from different perspectives. And then when it comes to the analysis in qualitative research, it tries to capture sort of detailed, rich understanding of the phenomenon rather than statistical regularities. So let's briefly think why qualitative research might matter, particularly for gerontology and for clinical practice. So I think it's really important, maybe from your perspective as doctors or in the sort of clinical field, to realize that older people are not just patients. So you might be kind of encountering them as patients, but actually when you see them in that patient-doctor encounter in that situation, you're only seeing a tiny little part of their lives. So instead, they kind of come to you with their life histories. They're embedded in family relationships and wider social relationships. They might have fears. They have certainly got certain values and certain preferences. So they're kind of bringing all of that to the situation. And so by conducting qualitative research that listens to the voices of people, you can start to understand things like, why do some older people refuse treatment, or why do they delay coming to hospital? Why didn't they come when the problem first arose? How do families decide who should provide care for an older parent? So how is the kind of whole care at home negotiated and arrived at? What do concepts like dignity, independence, dependence mean in later life? How are challenges like dementia, frailty, chronic illness experienced, and how do they impact on people's daily lives? So we might just sort of think of them as kind of bodies and how illnesses impact on their bodies, but actually often it's much more interesting to understand how they manage their daily life with those illnesses. And also, why might it be difficult to actually implement the sort of advice that you as doctors give them? Why can it be difficult to implement that at home or in the daily lives? So I think these are the kinds of questions that maybe would be interesting topics for research if you have a kind of more clinical background, but you're interested in older people. So qualitative research, specifically in gerontology, tries to understand how people make sense of their experiences as older people or as they are growing older, focusing on their own worlds and their own social context. So what is it like to live with stroke or diabetes? How does an older person understand the help that they're being offered, whether that's clinical help or help from a family? How do older adults balance independence with needing care? So that's something that's very much at the heart of my research on older people's care. How do they manage to kind of maintain some degree of autonomy and decision making if they're actually quite dependent on other people? And how do culture, religion, gender, family expectations, all of these contextual factors shape later life and illness experiences in later life? So because in qualitative research, you're really focused on understanding individuals' experiences, opinions, behaviors, attitudes, this really means that you should treat your participants as the expert. So they're the expert on the topics that you want to understand. And therefore, it's really important that we create a research situation or environment where they feel that they can be heard and share their expertise and be respected for it and not judged for it. But then students sometimes sort of struggle with that and they say, but look, I've interviewed, I don't know, 50 different people and they all tell me something different. So what's the truth about this topic? Who should I believe? And I think it's kind of part of becoming a kind of qualitative researcher is sort of part of that is letting go of this idea of that there is one truth out there, but instead that you have to kind of take what everybody tells you and think about, well, what are they telling me about their own experience in this situation? So why are they saying what they're saying, even if we have certain doubts about it, or even if it doesn't kind of capture kind of the scientific understanding of the world. So if they say, I don't know, dementia is really a form of gila, what does that really mean? And we shouldn't then as researchers just say, no, that's wrong. We have to think about, well, if that's their perception of dementia, that might explain why people are treated with dementia are treated in a particular way. So it's sort of trying to get at these kinds of truths rather than objective truth. Okay, so if you're doing qualitative research, then there's obviously different ways that you can collect your data. Here are some of the most common ones, and I'll focus particularly on in-depth interviewing and participant observation or ethnography. But you can also do focus group discussions, so group interviews where you're really kind of trying to profit from the kind of interactions between participants. You can ask participants to keep a diary about their experiences. So that can be interesting. For example, if you're doing research about carers and caregiver burdens, then asking them to keep a diary of all of the things they do every day and how they use their time in providing care, and when they feel positive about this and when they feel overburdened or tired or something. So diaries can be really valuable for that kind of research. And then some people, some qualitative researchers really focus on participatory approaches. So they really kind of try and work with the participants already when they're designing the study to think about, well, what's really important to you? What are you trying to, as the study participants, what would be useful for you to find out? And then you might involve them in the data collection. They might become interviewers and help with the analysis. And then increasingly people like to use film or photography in their research, or use creative methods. So get people to draw something or take photographs of something, or walking interviews. You might kind of, if you're trying to understand how maybe a person with a disability, how they can still use space or navigate their environment, then actually doing an interview whilst walking with them through the spaces that they use can be really, really valuable. So these are just some ideas. So let me say a bit more about in-depth interviews. So usually qualitative researchers use something called semi-structured in-depth interviews. And by semi-structured, what you mean is that you have a number of questions that you want to ask. So you've thought about the questions you want to ask in advance of the interview, and you put together an interview guide or an interview schedule. But then you kind of use it flexibly in the actual interview, because maybe you have 10 questions and you start with questions number 1 and 2, but then the participant already kind of jumps ahead and talks about something that's relevant to question number 7, and that's fine. You don't say to them, okay, stop talking about this now, we're going to come back to this later. You're just going to sort of follow them and finish that topic and then move on to the next. But the key thing is really that you're trying to understand the participant's point of view, not your own participants, not your own position. So that's why sort of listening is really important. So in semi-structured interviews, the interviewer has a flexibility in not just the order of questions, but you can also change questions slightly or reword them. So sometimes you might have a question, but the participant doesn't really know what you mean, and then you kind of find a different way of asking it. Whereas if you were thinking of quantitative research where people have a survey, there it often really matters that the question is asked in exactly the same way of every participant, because otherwise it doesn't it becomes invalid. That's not a position that we have in qualitative research. And often participants will go off topic, so they won't necessarily kind of stick just to your questions. You ask them something that reminds them of something else, and they then talk at some length. And sometimes that can be frustrating because it's really not relevant. But quite often, some of the best data that you get is from people going off topic and telling you what they think is important, and then you suddenly realize that they're telling you something that you hadn't thought of before. So that can actually become an important part of the analysis, because suddenly people are talking about something that matters to them, but you hadn't anticipated. So here's just a couple of examples of what interview questions might look like in a semi-structured interview. So very often you want to start with a very open question. So I understand that you provide help to someone who is sick or disabled. Please, can you tell me a bit more about that? So you're basically just telling the person, okay, I'm interested in your role as a carer. What you want to tell me about that? And so it's a very, very open question, and it allows them to really get off their chest what they want to, or to clarify what exactly you want to know. So some people respond really well to such a very open question, and some people might be a bit confused and say, well, what you want to talk to, what exactly do you want me to talk about? So that's why it's always important to have some kind of follow-up questions or probing questions. So, well, for example, you could start by telling me how you first became a carer. So that's a kind of, you're directing them to think of the beginning of their experience as a kind of follow-up question. And then sometimes people might give quite a short answer to your question, and then you might follow up with a probe. Please tell me more about why you felt that way. So I felt angry, or that made me really angry. And you could just stop there, but then you're going to get back to your computer later, and you think, oh, I wish I'd asked why did they feel angry. So that's why it's really important to be listening to what people tell you, and ask that kind of follow-up question, tell me more, when they say something that's quite interesting. And then sometimes we might use quite closed questions. So could help from health professionals help you in your caring role? And they might just say yes or no. And that's a bit frustrating. So that's why, again, you have to have a kind of follow-up question. So what kind of help do you think would be most useful? So it's really kind of developing the art of asking questions that encourage people to say a lot rather than just give a sort of one or two word answer. So here I've just kind of put some advice on kind of questions that don't work so well. So if you have a very, very long question, by the time you get to the end of the question, especially if it's an older person or someone who's maybe not so educated, they might not be able to keep track of a very long question. Sometimes it's very tempting, and I've done this myself, is to put too much into one question. So do you think that people over 65 and people with disabilities should have free access to public transport? Then that means the participant doesn't know, am I supposed to talk about people over 65, or am I supposed to talk about people with disabilities? So break it down. Always just have one question at a time. Don't use acronyms in your questions, or if you're talking to people whose experience or educational status is not so high, then don't use kind of very technical terms. So Alzheimer's disease might not be something that's at all familiar to say someone in a say village population, and so you have to kind of find the words that might the terminology that's more accessible to them. And then it's really important not to use leading questions. So questions that already tell the participant what you are expecting or wanting them to say. So I imagine you were upset when your mother moved into the care home. Maybe the person was really relieved and thought this was like the perfect solution, that the mother moved into a care home because that's where they're being cared for best. But by saying, I imagine you were upset, you're closing down that possibility of them saying, oh no, actually it was something quite positive, because you've signaled to them you are expecting them to be upset or unhappy. So that's a really bad idea. And similar to leading questions can be biased questions. How do you think the awful care older people receive in a care home could be improved? So you're already kind of again signaling that you think that something is bad rather than neutral. And then similarly, it's often not a good idea to have a kind of too open questions. So tell me everything you know about older people with dementia. That's just kind of too big. You have to sort of break it down a bit more. In the kind of actual interview encounter, it's really important that you sort of listen to what the participant is saying, and kind of also paying attention to some of the non-verbal cues. So kind of facial expressions or body language can be really important to tell you, are they comfortable or not comfortable about what they're telling you, for example. And then really kind of try and put yourself in the position of the participant and anticipate that they might be shy or they might be nervous, particularly if maybe you're doing an interview as a doctor. Then there's this kind of hierarchy. You're the kind of clinical person, maybe even in a white coat, and so they might be feeling very, very nervous, or the topic might be upsetting, and so it's really important to pay attention to that and be empathetic and create an environment where people feel safe and happy to share thoughts. And then when you first start doing interviews, it can be really, really tricky to cope with silences. So you've asked a question and the person maybe says something, but then kind of stays silent for a while. But I think it's important to allow that, because partly that could be because there's a lot of emotions going on in the person, but it might also just be that they're thinking about the question, that you're asking a question that they hadn't thought about before. And if you immediately rush them on to the next question, you are not giving them a chance to really think about the question and come up with an answer. And then it's really important to not be judgmental or not to react in a strong way to what people tell you. So if you express shock at something that someone tells you, they're going to obviously shut down and not talk more. So just try and be very kind of open and non-judgmental. So it's really this kind of art of listening carefully to what people are telling you, so that you're kind of sensitive to where you want to ask some follow-up questions or create the space so that people can talk more, because actually they've got something interesting to say, and when you've kind of finished with a topic and it's time to move on. So it's this sort of very active listening that can be important. in qualitative research, we always very much emphasize the fact that the researcher is part of the research instrument. So you can't take the researcher out of this the data collection situation. I mean, I would say you also can't take them out of a quantitative data collection situation either, but it's much more obvious if you're spending like an hour or 2 hours with a person and asking them quite detailed questions about their lives, then that interaction between you and the participant is very, very important. And so you have to be mindful of how your identity, your age, your educational status, your ethnicity, how they might kind of influence the information that the participant will give you. And so particularly if you're doing research in a sort of on a topic of health, around health, medication, treatment, and so on, you have to think carefully whether you want your participants to kind of see you as a clinician, or whether they want to see you more as a kind of researcher who's a lay person. And so it will matter how you present them yourself, and whether you wear, I don't know, a white coat or not. So what signals are you sending? But if you very much send the signal that I'm doing this research as a doctor, then participants might be shy of saying something that they think you disapprove of, like, I don't actually take the medication when I get home, for example. But also it might mean that they kind of expect something back from you. Oh, I want better treatment, or I want kind of to be seen more quickly, or I want access to this new medication. So it's also kind of managing the expectations if you have these two roles. On the one hand, you're a researcher, on the other hand, you're a clinician. So you have to really think about how you want to manage this. And then particularly if you're doing research with older people, the temptation it's very, very often the case that they're not alone, but that the family member will be with them, certainly in my own experience of doing research with older persons. And then the temptation is that the family member will speak for the older person, or might correct some of their answers. And if you're really interested in the voice of the older person, then you have to kind of find a way of kindly saying to the family member, can I listen first to what the older person has to say? So really sort of managing that interference can be really quite difficult. So here I just want to very briefly talk about a study that was done in Ireland. So the study wanted to understand how people with dementia experience daycare, residential respite care, and in-home care services, and whether these services support their personhood. So the researchers did in-depth interviews with 6 community dwelling people in Ireland who had mild or moderate dementia. And they did face-to-face semi-structured interviews lasting between 20 and 65 minutes, using really open questions, flexible prompts, being quite empathetic, giving people plenty of time to answer, because they had dementia. They sometimes kind of had to ask the question a few times, and then sort of checking back whether the researcher had understood the answer correctly. What they found, I mean, the findings are not so important for this purpose. So they found that day services were more acceptable than residential respite care. So they didn't like being taken out of their familiar setting. And some participants said that they received respectful care, and others felt that they'd been sort of infantilized, that they weren't given enough choice, and that somehow their personhood was not respected in these services. So in terms of how this research actually kind of made sure that it captured the voice of the people with dementia is through the following strategies. So first of all, they were very clear that they wanted to hear directly from the people with dementia. They didn't want to kind of hear the perspective of the caregivers or the service providers. So they kind of put a lot of time and effort into making it possible that people with dementia can take part in the research, that they understood the aims of the research, that they gave consent, but also that they asked questions in a sort of simple way that allowed the people with dementia to answer. So they didn't have complicated questions, but they had questions like, well, what is this service like, or how are you treated? And so the questions were designed in such a way that the people knew and understood how they could answer them. So here's just a few quotes from this research. I don't want to go and stay anywhere. I need to have my own thing here. So the answer is kind of maybe phrased quite simply, my own thing. What they probably mean is that they need to have their kind of familiar things in a familiar surrounding. They don't like going anywhere else. Or a woman said, when I cook and bake for them, I feel like I'm not just some useless and helpless person, like I matter. So by using words like useless and helpless, that gives you an idea that some of the time, or maybe even a lot of the time, this person feels useless and helpless, but actually given a task that they can still do, like cooking or baking, maybe with some help, that's when they kind of still feel like a proper person, and that's when their kind of personhood is restored. Or then one man said, nobody asked the right questions, therefore they are all losing out on an opportunity of learning from us. So this is sort of a kind of complaint from the person saying the service that they're providing for us isn't really ideal for us, and we have some ideas of how it could be changed, but no one is asking the right questions. No one is listening to us. So I think this is a sort of good example of using qualitative interviews in order to hear the voices of people. Okay, let me talk now. Shall I just carry on, or should I take questions from the audience? I should have clarified that before.
Well, I think shall we continue first, maybe?
Okay. I'll get to the end of the lecture, and then we can you can ask questions.
Yeah,
So
sure.
thank you. So the other qualitative research method that I think is particularly valuable for hearing the voices of older people is participant observation or ethnography. So just to clarify, the terminology ethnography and participant observation is often used interchangeably. So some people talk of ethnography and some about participant observation, but really they typically mean the same thing. So participant observation involves the researcher being present in the study community or amongst the study population for a prolonged period of time. And the aim is very much to kind of understand an issue from the perspective of the study population, but also in the context of the study population. So to contrast that with say, individual interviews, so you could imagine if you're interested in the medication adherence and sticking to treatment at home after you've sent a patient home, you can interview them obviously in the hospital about this. So maybe you send them home and then 6 weeks later they come back and then you say, oh, so how did you actually stick to the treatment plan that we gave you? So that's getting their perspective, but you're not actually seeing how this is done in the context of their daily lives and in the context of their home. So I think one of the key things that participant observation adds, or why it's different from just doing interviews, is that you are kind of present in the context in which people live their lives. So you're getting people's views and actions, but in the location that they actually inhabit, and I think that can be really enriching. So in terms of the key characteristics of ethnography is this sort of long-term immersion in the social setting, which is often referred to as field work, and that the researcher aims to participate in the activities to some degree. I'll say a bit more about it in a minute. And so that really means that you have to be able to speak the local language and somehow kind of fit into the kind of context. The emphasis is very much on kind of contextualized information, understanding. So you're trying to understand the behavior within its context. So that's why this contrast I made earlier between interviewing someone in a hospital setting about what happens at home versus actually going to their home, or if you're interested in how nurses operate in a hospital, then it would make more sense to kind of study the nurses within the hospital setting rather than in a cafe asking them about their kind of what is it like to be a nurse in a hospital. So it's sort of trying to kind of capture the phenomenon in its natural context. If you do ethnography, you're often trying to kind of see the world through the eyes of the people you're studying, and that's why kind of participation matters. So actually kind of when I was doing fieldwork in Pakisaji, when I lived there for 1 year, I would obviously not become a Javanese villager, but I would try and kind of participate as much as possible in the lives of people there. So going along to weddings or helping when there was a slamatan and the women were sitting on the floor making little cakes or putting cakes into boxes to kind of be there and take part in that, and go to the fields to see what is it like to work in the fields, because you're sort of trying to get an understanding of what is it like to be, I don't know, an older person in a Javanese village. And typically, if participant observation starts from the assumption that of relativism, so that it means that you might kind of come with certain assumptions to a question, but you're trying to set your own assumptions aside and try and understand the phenomenon from a different perspective. So you as doctors might have really detailed and scientific understandings of a particular illness, but what you're trying to do when you're doing an ethnographic study of that illness is to understand how do the people understand that illness. And that might be very different from the kind of scientific understanding, but it's kind of what you're interested in that moment. some of the advantages of participant observation are that they kind of really facilitate the development of rapport, because you're spending more time with people, so they hopefully get used to you and begin to trust you. I certainly found when I was doing fieldwork in Malang, so I spent a couple of months. The first couple of months I spent there, and then I went away for a couple of weeks on a holiday, and then coming back again. That really made a big difference, because people then initially they maybe just thought, oh, she's just here briefly, but then when I came back again, they thought, oh, okay, she's really kind of invested. So then people began to open up more. Participant observation can really help to reduce reactivity. So often if you start observing a phenomenon or asking about a phenomenon, people first of all kind of really react strongly to the fact that they are being interviewed or observed, and so they change their behavior in that situation. But by being there long term, they forget about that, and they kind of they forget that they're being researched, and so you get more kind of naturalistic data through that. Participant observation, the observation part is important because it allows you to see things, not just hear what people tell you about something. So you get all of this additional information. So for example, how people talk to each other, the body language can tell you so much about the kind of quality of the care that they're giving, or the quality of the relationship. So the sort of observational data is really important, and it helps you to kind of capture some of the nuances. So if a caregiver feels exhausted, that's something that you can maybe not hear in what they're telling you, but you can see it in the face, or you can see it in the body language. So typically, if you're doing ethnographic research, you use a number of different techniques to collect data. So observation is one of them. You might have a lot of casual conversations where you're not kind of taking notes or using an interview guide, but you're just chatting. But then later on, you might make some notes about what the person said in the chatting. Then you, of course, also use semi-structured or group interviews as a way of data collection. You might draw some maps and diagrams. You might take make films or photographs. So you're basically trying to collect as much data as possible. Okay, I think I'll skip over that. So observation is a kind of element within participant observation, or it can be an element within participant observation. So sometimes you might only observe and ask no questions at all. So for example, if you wanted to do research on in an intensive care setting, or in an operating theatre, if I was a researcher, then it really often wouldn't be appropriate for me to kind of ask questions. So I would only be observing. On the other extreme is pure participation. So I'm a nurse, I'm working as a nurse, I'm in the operating theatre as a nurse doing my stuff, but at the same time I may be thinking about what am I doing, and then later I might sort of write that down. Most commonly you sort of mix up participating and observing. So you're kind of taking part in some parts of the activity, but you're also allowed to sort of stand aside and make some notes at the same time. So why is it good, or when is it valuable to use observation? I would say that sometimes it's the only way that you can collect data. So for example, when linguistic communication is impossible or difficult. So if you're doing research on a person with advanced dementia, then you might really not be able to ask any questions anymore. But using observation about how they kind of interact with others and what they're still able to do for example, you could get from observation. Sometimes it's not appropriate to ask questions. So in the middle of a ritual, for example, you just have to observe. You can maybe ask some questions afterwards, but not whilst it's happening. Sometimes it's really important to understand how something is done. So to really understand the kind of detailed actions and processes involved in a particular phenomenon. So caregiving to a person who is paralyzed and lying in bed, you might really want to see, how does the caregiver do it? How do they change the bed? How do they bathe them? How do they feed them? So then observational data is more important than asking them to describe what they do. And then a lot of things are better, more easily captured through observation than through questioning. So emotions, much better to see emotions. I mean, you can also hear people when they say, "Oh, I was angry," or "I was sad," but a lot of that you can see. People's economic circumstances, I found in the village setting where I went into lots of different people's houses, I could see from the furniture, the quality of the housing, the things that they had, I got an impression of their economic circumstances without having to ask them embarrassing questions about income. And so on. And then the other thing is that observations can often be a check on what people say to you. So quite often an older person might complain to me, "Oh, my daughter never comes to see me. She's completely forgotten about me." And then 5 minutes later, the daughter walks in. And so if I hadn't been there to observe that, I wouldn't have been able to kind of contrast what's, because that then made me think, why is she telling me this? So why is she presenting herself as a neglected, abandoned woman, when actually her daughter is very much involved? Of course, qualitative research generates all kinds of ethical issues, but I would say that participant observation maybe has particular strong ethical challenges because it can be quite intrusive. You're spending a lot of time around people, so there's always the danger that you're invading their privacy. They might forget that they're taking part in research, and in some ways that's what you want to happen. You want them to forget that you're there studying them. But then the question is, are they also still giving consent? So it's important to kind of check in with your participants again at key points, especially if they maybe have an outburst where they really kind of complain about something or cry or shout at someone, and then to say, are you still happy for me to be studying this, or would you like me to just kind of ignore that and not collect that bit of data? And then confidentiality can be particularly challenging as well in participant observation, because you're getting information from so many different people, and you always have to remember, this person told me this, so I must be careful that I don't tell that person over there that she said this. So you're kind of having to kind of think about the relationships between people, say in a care network, and what you tell them, what you share, that one person told you in terms of the next person. And then anonymity. Usually when we do qualitative research, we promise the participants that, oh yeah, you will be anonymized, you'll get a different name in the writing up of the research. But that can actually be really tricky if you've got very, very detailed, rich data about people, and you want to put that detail into your writing, into your article, but then other people might recognize the person because there's maybe only one person in that village with dementia and 7 children. So then you have to think about, how can I change some of the details so that the person can't be identified, but you're not changing too much so that you're still true to the data. So these are some of the challenges to think about. And then maybe thinking of doing qualitative research with older participants, whether that has kind of particular ethical challenges, and I would say probably yes. So consent might need particular effort if you're interviewing people who've got memory problems or don't hear very well. So then you have to kind of think of creative ways of involving them in consent and making sure that they really understand why they're being included in the research. Then, as I already hinted, privacy can be quite difficult. So because older people rarely live on their own, they often live with others, and that can then mean that in the interview or in the data collection situation, other people are present, and are they kind of chipping in too much? Are they kind of taking over the interview? I certainly found that, especially in the beginning when I started doing interviews in Malang, it was really useful to have one of my assistants with me, because I could then sort of chat with the family member, and the assistant could talk to the older person, because otherwise the family member would constantly kind of interfere and give answers on behalf of the older person. And the other thing is, of course, the older person, if the carer is present, might not want to say anything bad about the care, or might not, might feel inhibited about what they're willing to share. Then to kind of remember to come back to the sort of idea of positionality, and you as the researcher, if you're a clinician, then you have to think about whether your role as with a health professional background might kind of put pressure on the older person to participate, because they don't feel they can refuse, or because they hope that they're going to get something in exchange. Then it's important to be sensitive to what might be an upsetting topic. And often when we're studying older people and old age, there are a lot of topics that are quite challenging and difficult. So you might be interested in issues around being dependent on others, or having ill health, or experiencing decline or bereavement. So these are all kind of topics that are quite common in later life. And so you have to anticipate that people will get upset in the data collection, and how you then respond and say, okay, do you want to stop? Should we just take a pause? Sometimes people just want to get something off their chest, and they're quite happy to carry on with the interview, but there's a need for sort of empathy and giving them a bit of space if they get upset. Anonymity I already talked about. So yeah, you have to kind of plan for distress. You also have to plan for what are you going to do if you hear about a situation that does look like abuse or neglect. Are you then kind of going to break the confidentiality you'd agreed with the participant because you've got safeguarding concerns? So those are again things that are best to think about in advance. So you're really kind of trying to walk this tightrope of, on the one hand, protecting the older person in your research, but at the same time not overprotecting them by kind of saying, oh, well, if there's any form of kind of cognitive decline, then they can't take part, because then maybe they can't give proper consent. But if you do that, then you're also disempowering people to take part in research and having their voices heard. So I think for 4 years I was chair of the ethics committee in my faculty, and I often had to grapple with this thing that on the one hand, yes, we want participants not to be harmed by taking part in the research, but also we have to be careful not to exclude them from research just because we're so worried about their vulnerability. So those are kind of challenges to bear in mind. Okay, so again, I'll give you an example. So this is a fascinating ethnographic study on family caregiving in families where a family member had early onset Alzheimer's disease. So they were maybe only in their 50s or so when they developed Alzheimer's. And the researcher was mainly speaking to the spouses, or the husband or the wife of the person with Alzheimer, and wanted to kind of understand how they experienced the change in the relationship between husband and wife in a context of Alzheimer's disease. And the starting point was kind of that the participants would sort of say, oh, the partner is now like a child. And often we as gerontologists get kind of alarm bells start ringing. So, oh, this is infantilizing. They're kind of comparing the person with Alzheimer's disease to a child. That's a bad thing. They shouldn't be doing that. But in this research, by really spending a long time alongside these couples, so the person did 26 months of ethnographic fieldwork, really spending a lot of time in people's homes or going along to the clinics or the day programs, support groups, restaurants, and so on. So they were really sort of following these people around. I think they focused on these 6 families. So then they kind of could really understand how by using this language of, oh, they're like a child, it was kind of capturing the reality that the person was no longer a husband or wife, or a lot of the elements of a kind of marital relationship had been lost as a result of the illness. But by referring to sort of parent-child relationship, at least the people were still holding on to the idea that there is a relationship, a caring relationship, a reciprocal relationship. So by kind of making jokes or observing how people kind of interact when they're getting dressed or being fed, the ethnographic research sort of showed how people manage that kind of relationship. So here again are a few quotes. The marriage part is over. I feel like he's a kid. But then also people say, when you know so much about somebody, that's the intimacy that you have. So there's also these sort of moments of really positive sharing of still remembering the marriage and what it was like, and having a sort of joke together. So I think this is a really nice example of how ethnography can help you to understand something that's quite complicated, and how a marital relationship changes as a result of Alzheimer's disease. Okay, let me end very briefly with, for this first lecture, with some of the criticisms that often get made of qualitative research. So people often say, oh, it's too subjective. There's not enough transparency about kind of how the research was done. You can't possibly replicate qualitative research. The sample sizes are too small, and it's really difficult to generalize from qualitative research. But I would sort of argue against that. I would say that you can handle the subjectivity of qualitative research on the one hand by sort of saying, well, that's the whole point. You're trying to kind of get at people's subjective experiences. And in terms of the kind of subjectivity of the interpretation, so the subjectivity of the researcher, you can sort of try and keep a track of that by being very, very reflexive and constantly asking yourself, how am I kind of co-creating the findings? How are my assumptions shaping my interpretation? So I think reflexivity is a good way of tackling the subjectivity. The criticism of lack of transparency, I think, is a real criticism. And certainly when I started publishing qualitative research 20 years ago, the expectation of what you put in your methodology section was very minimal. You just could describe, oh, well, I did 12 months of ethnographic fieldwork in a village, and mostly the journal was happy with that. Nowadays, there's much more expectation that you really keep a careful audit trail and really kind of describe the research from the beginning to the end, the decisions you made. You include your interview guide. You explain how maybe you had to make changes to your study design as you went along. So you're just sort of much more kind of open and honest about describing your research. The criticism that you can't replicate qualitative research, I think, is true, and it's fine. But on the other hand, you can also, and there have been now replication studies using qualitative research. And the key thing there is that, again, you sort of really describe your methods, your context, and your data in detail, because then in theory, someone else could try and replicate the study in a different setting or a few years later. To counter the criticism of small sample sizes, you can say, well, but my sample is small, but it's very carefully curated. I've really kind of thought about having the right diversity in my sample in terms of, I don't know, gender or living arrangements or care situation. Or so don't just say, oh, well, I just took the first 5 people who were willing to take part in my research. Really kind of explain what were your inclusion criteria, why did you select these people and not other people. And then in terms of the kind of criticism that it's not possible to generalize from a qualitative research, I always kind of disagree strongly with that criticism, because I think you can derive really deep theoretical insights from qualitative research that then transfer or resonate with in a different setting. So we're not aiming for statistical generalization, but we're looking for more theoretical insights or conceptual insights that we can then kind of apply or at least explore whether they also fit in a different setting. Okay, I shall stop sharing my screen and give you a chance to ask some questions, I think.
Yes, thank you very much, Bu Eli. This is a nice lecture, very interesting, and also a challenge for me because this is something new for most of us, I guess, about qualitative, because most of us, I think, usually involved in the quantitative research. So we are very open for any questions, and Bu Eli will be very happy to give us more enlightenment.
No, please ask some questions. I wasn't sure kind of. I hope I pitched it right because I wasn't sure how much knowledge already exists.
Okay, well, we have one question in the chat box.
Yeah.
So this is from Dr. Andika. Okay, he is our resident of internal medicine. So he asked, in your slide, you mentioned how interviewer traits like age, profession, or status can create bias or fearful of consequences in participant. So as novice researchers, how can we effectively minimize this hierarchical power dynamics?
That's a really, really good question. So I think the first thing to sort of ask is kind of whether can you as the researcher take minimize the kind of your interview traits. So if you are a clinician and you want to interview patients, but you really want to make them feel at ease, then the advice I would give is try and interview them not in the hospital setting, maybe in a cafe. Don't wear the kind of markers that mark you out as being a doctor. I mean, don't say don't pretend you're not a doctor if you are a doctor, but really by kind of wearing casual clothes, having the interview, say in a cafe or in the older person's home, rather than in a clinical setting or in your kind of clinic. You can signal to them, look, I want to hear your voice. I'm not here to judge you. I'm not treating you in this situation. And the other advice, so try and kind of get rid of those markers, try and reduce the social distance, but also ideally don't study the people that you are directly treating. So it's often advised that you maybe recruit someone from your colleague who are the patients of your colleague rather than the people that you yourself are treating. So that's my advice.
Because maybe if we observe or we do research in our own patients, maybe it's more biased.
Yes, and so it means you obviously know a lot more about them, which can be valuable, and maybe that sometimes that's important. But on the other hand, it makes the participant more confused. Are you kind of asking me as your doctor, or as you asking me as your researcher? And if you, for example, asking them about treatment adherence, if you ask the doctor, they're going to say, yeah, I do it. I always take my medicine. But that's not what you want to understand. You want to understand some of the challenges that they might have.
The patient maybe get more pressured when you ask about the medication.
Yeah.
Well, no, also interesting. I have one question about bias.
Mm-hmm.
How to minimize? I mean, in the qualitative research, I believe there is more potential bias, such as interpretation bias.
Mm-hmm. Mm-hmm.
How to minimize such bias in qualitative research?
So I suppose the interpretation bias is, you just have to really do your research, your analysis quite rigorously. So don't just read your data once or twice, but read it lots of times and start coding it, and then you might develop an idea. I think this is what's going on here. I think they're telling me this. But then also ask critical questions of yourself. Well, why did they say that? Am I really looking for the surface meaning here? I take my medication. Or is there something deeper going on? Are they signaling something? I take my medication, but actually what's going on here is that they have difficulty with that. So obviously you can't just then make that up. So, but then you're kind of looking again through the interview transcript and say, are there any hints in there that they're kind of actually telling me about the difficulties? Yeah, I take my medication, but it can be difficult. So then you're not picking up just on the first part of the sentence, but also on the other. So it really means, spending a lot of time on the analysis. And when you've maybe developed some idea, some interpretation, then maybe check your other participants. Because you're often not just interested in what one person told you. You want to try and arrive at some kind of shared meaning across your sample. So then you kind of just keep asking questions of your data. But the other thing that I always like to put back at quantitative researchers when it comes to bias, how are you so confident in your quantitative research that
That's yes.
the people understood the question correctly or didn't lie in the quantitative
Research.
interview?
Okay. Yeah. Thank you very much. So we have another questions currently
Mm-hmm,
from Dr. Andini. So
mm-hmm,
Andin, also our residents.
mm-hmm.
The LTC research often involves
Yeah.
interviewing nursing assistants, social workers, and families, not just the physicians.
Mm-hmm,
How
mm-hmm,
to triangulate across such different types of informants in the
mm-hmm, mm-hmm. Yeah,
analysis and writing.
yeah. Also, so with limited protected research
So,
or
yeah, okay.
statistic minimal
Minimal
viable
viable
quantitative.
qualitative project, yeah.
Mm-hmm, mm-hmm,
Yes, maybe Dr. Andin quite
mm-hmm,
interested in performing qualitative research, but since
mm-hmm.
the time frame, because she have to graduate soon, yeah.
Yeah, 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 yeah. Good, really good questions, really good questions. So, so the concept of triangulation is really interesting in qualitative research. So some people who have a more positivist mindset in qualitative research, they think that triangulation is basically to arrive at the truth. So one person tells you one thing, another person tells you another thing, maybe the third person tells you the first thing again. So two against one, okay, this is the truth. I don't think that's a really helpful way of using triangulation. So I would use triangulation as a way of shining light on a phenomenon from different angles and therefore getting a richer understanding. And if your, I don't know, your nurse assistant and your social worker and your family member disagree about what's going on in that long-term care setting, then that's interesting. You're not trying to kind of understand one truth. They're all telling you something true and valuable, but you the yeah, you have to take all of those perspectives on board. So you might say, well, the family carers spend the most time with the older person, so they have the deepest insight. And so what the social worker who only comes once a month sees is maybe partial, but they bring their professional perspective to it, so they might kind of understand better what's going. So you take something from all of the different perspectives, but you're not trying to aim at one kind of truth. So I suppose that would be my advice. And then in terms of a sort of minimum project, I think make your project very, very focused. So have quite a narrow focused topic. So don't go away and do ethnography if your time is short, but kind of have quite a focused topic. And you don't need a large sample size. I don't know, maybe 10 or 12 interviews is enough, but really put a lot of effort into those interviews. So really think carefully about your interview guide. Really make sure you create the best possible environment for the interview, that the person can relax and really listen carefully, ask those follow-up questions, so that you get the best possible data out of that those few interviews rather than doing lots of interviews. So do a pilot interview with a friend or someone, so that you really feel yourself comfortable about asking the questions. So that you get really good data, even though you're not doing lots of interviews, and even though your topic is quite focused.
Okay, thank you, Bu Eli. Well, I believe actually what most doctors do in clinical setting is a qualitative research, because you're asking patients, you're doing history taking, and then when you try to elaborate more on the social aspect of your patient, actually you're doing qualitative research,
Yeah, yeah,
but it's not the structured one.
yeah,
You
yeah,
can,
yeah,
but we have to make it more structured. I mean, what kind of information that you want to gain from
yeah,
the
yeah.
interview?
Yeah,
So
yeah,
I believe
yeah, yeah,
this
yeah,
qualitative approach is
yeah.
should be performed daily.
Yeah, yeah, and really kind of take seriously this idea that you want to understand the experience and the meaning. You're not just trying to extract information. If you want to extract information, then give them a questionnaire to fill in. But if you want to understand the experience, how they understand it, how they make sense of it, then the qualitative approach is really, really valuable.
Yeah, well, I believe the qualitative approach is I mean, maybe to treat human subjects as human.
Yeah, yeah,
It
exactly.
is.
Take that serious. Their humanity, their subjectivity, their frailty. Really take that seriously. But also understand that people live in a social environment. So you can't take them out of that environment, especially when it comes to ill health and treatment of ill health. We might have these very idealized ideas. Okay, this is how the treatment should be, but in real life, it's really messy, and it's so the yeah, taking seriously the messiness of life, I think, is important.
Okay. Well, thank you very much for the explanation. So maybe do we have any other questions, or maybe any of you want to ask directly to Bu Eli? Well, okay, another question. Oh, everyone is being shy today.
That's okay. It's okay.
Well,
Dr. Freddy Chandra, maybe want to ask? Dr. Freddy?
oke, Freddy ditodong sama Dokter Sri. Ayo silahkan.
Um, oh yes, sorry. There's another question, isn't there?
Yeah, we have another
Yeah,
question
yeah.
from Endo.
The importance of active listening, probing, and following the participant's direction. Yeah, often face strict time limits. How do you strike a balance between allowing to go off topic and
Okay, yeah,
time of the interview? So,
technical.
I guess I would ask. I, I would say that don't try not to put yourself in a time limit for the interview. Rather do fewer interviews, but don't rush the actual interview. So I think it's really important in that interview moment, in that hour or 90 minutes or 45 minutes, that there's not this sense of I have to rush. You should go into the interview thinking I've got enough time. Naturally, people after an hour run out of energy, and the answers get questions, but try not to kind of give them less than an hour. And then the off-topic thing is important. I mean, sometimes you really think this is off-topic, and then you, I don't know, you sort of say, oh, that's really, really interesting what you just told me, but can I please just bring you back to this to this question, or oh, that's really fascinating, but look, I've got something really important I still want to ask you. So you have to kind of obviously stay polite and keep the person engaged. There's no point in kind of saying, okay, enough yet now, if they then don't want to engage with you anymore. But sometimes you do have to bring them back to the focus of the interview.
So I see from one of your examples, the interview lasting the range is 25 to 60 minutes, because
Yeah,
the range is quite wide, because yeah,
yeah,
we have to
yeah,
allow the patient, the subjects to tell us.
yeah,
So this is
yeah,
quite interesting.
yeah, yeah,
Based on your experience, I mean, I heard from Dr. Sri that you also perform research in Pakistan in
yeah.
Indonesia and maybe in other country. How do you think? I mean, for me, when I'm performing daily practice, usually some of Indonesian people, uh, yeah, they tell too much. And then maybe that's what Dr. Edo mean, go off topic sometimes. And they also like to make some hypotheses about their disease.
Yeah, but that's fascinating. That's what you want. That's really what you want. So I mean, I'm not a medical doctor, so I don't know very much about the scientific understanding of illness and disease. But I think that's exactly the kind of fascinating thing to hear. What do people think is wrong with them, or what caused their illness, or what will make it better, or will anything make it better? So I think that's exactly the sort of fascinating stuff. So you can worry after the interview that if they tell you things that show that they really don't understand, that they have damaging ideas, ideas that are not just wrong but also bad for their health. You can then separately think about, okay, let me produce a leaflet or feed something back or do some information campaign. But in the interview, you just want to listen. You want to hear these understandings, because you'll never be successful with your treatment if it is opposed exactly to what
their
people
beliefs,
believe. If they don't believe that not eating cake when they've got diabetes is harmful, they will not change their behavior. So it's trying to understand it and then work with that understanding. So one of the big problems in my research is that so many people think that illness in old age is just
normal.
sakit tua, sakit tua. So nothing you can do about it. And you then, once you have that understanding, then you can start working with people and saying, okay, some things are maybe natural in later life. We get a bit more tired, maybe our hips hurt, our knees hurt, but look, high blood pressure, you can actually go and see a doctor. Or this problem, there is actually medication for it. So to sort of then engage with people and get them on board with your treatment. But first of all, you have to understand their ideas. So even if they're scientifically completely wrong, you want to hear those ideas.
Because that's also the challenge. I think they sometimes they come into conclusions, they even jump into some hypotheses and so on. But okay, so that's important point. That's what we want to get from the qualitative research.
Exactly. You don't go to some older person in a village because you want to understand medical knowledge. You go to university to understand medical knowledge, but to understand their perspective of illness and their explanatory model of illness. For that, you treat your participant as the expert. That's what they are the expert on.
Okay. Well, so do we have any other questions? Maybe any of the participants want to ask directly? We have
Indonesia juga boleh.
Bu Eli very good at Indonesia. Silahkan Bapak, Ibu, Dokter. Saya lihat juga ada beberapa yang dari luar Malang. Terima kasih sudah hadir. Ada Dokter Nuri dari Palembang, ada Dokter Estika dari Jakarta.
Okay.
So
then,
maybe
should I move on to my other lecture?
Okay.
Because I've got another one. This one will be a bit shorter.
Okay, please.
But let me just do that. And then go back here. Where's the share screen gone here? Okay. So in this second lecture, I want to talk about cross-cultural perspectives on aging and care. And in this lecture, I draw much more on my own experience of doing comparative ethnographic research on aging and care in Indonesia for the last 25 years or so. So through my lecture and examples, I hope to convince you of the value of approaching aging and care through a cross-cultural comparative lens. And I'll also introduce you to some of the key methodological principles of cross-cultural research and some of the conceptual challenges that you need to bear in mind when doing cross-cultural types of research. But let me start with an anecdote from when I first started doing research on aging and older people in Indonesia. So in 1999, when I first visited the village in Pakissachi, where I later carried out more than 12 months of fieldwork, I explained to the people in the village office that I was interested in older people's support networks in Indonesia. And then someone in the village office said to me, you know, Ellie, here in Indonesia, we don't throw our old people into care homes like you do it in England. Here, the family provides care. I, of course, tried to defend my country. I said that we did not actually throw older people anywhere, and that most older people in England don't enter a care home because they've been abandoned, but because there's a positive choice and a good reason why they enter a care home. I also then asked the village official whether family support was really universal in Indonesia, or at least in this village, and whether there weren't perhaps even in Pakissachi some older people who live on their own. But the village official at the time denied this. They said, no, everybody, all older people are cared for by their families. In fact, as I then started collecting data in the village, I found out that about 1 in 10 older people did live alone, and some of them were genuinely didn't have family to look after them, and some of them just lived near to family and were still getting care. So I begin with this story because I think it captures several important features of cross-cultural comparison. First, comparisons of care or of other practices are often moralized. By this, I mean that they're used to exaggerate differences between countries or between groups, and they're used to make a judgment, often a negative judgment, about the other group, so to make the other country or the other group look inferior, and the own culture, the own country, as being superior. So from the viewpoint of the village official, residential care in England looks like abandonment, but from an English perspective, reliance on your children for money and for care and for healthcare costs looks quite humiliating and certainly very unreliable. So it really depends on your perspective. Second, cultural stereotypes are often empirically incomplete. By this, I mean that the official statement that the family provides care clearly expresses something important. It expresses an important cultural norm. It expresses also a lot of reality, but it doesn't cover all of the reality. So that's what I then found out by actually doing the research on family care and support. I found out that no, not every older person is cared for by their family. So cross-cultural study can help us to unpack some of these stereotypes and understand how much of how far are they grounded in reality, and where is actually the reality a bit more complex than the kind of stereotype or the general norm maybe suggests. And then third, the anecdote opens up a central question that's really also at the heart of this lecture, which is, are differences in social practices, so in this case between England and Indonesia, are they primarily cultural, or are they produced by differences in opportunities or differences in constraints? For example, availability of health services, pensions, family networks, etc. So I would argue that most practices and realities are only partly shaped by cultural differences. Culture matters, but it doesn't act alone. And this becomes clear when we take the England-Indonesia comparison a bit further. So in England, healthcare through the National Health Service is free at the point of use. If you go into hospital, even if you have a really complicated operation and you have to stay there for many weeks, you do not have to pay for that. In Indonesia, health insurance has in recent years expanded, but out-of-pocket payment for healthcare is still very common. A lot of people do still have to pay quite a lot of their own healthcare, and some people become impoverished as a result of having to pay for healthcare. So I don't think Indonesians would say that as a deep cultural preference, it's better when a family has to worry about paying hospital bills rather than relying on the government for healthcare. So when it comes to healthcare, I think most people would agree that actually it would be better to have the English system of where the state pays for healthcare from taxation. So by contrasting kind of on the one hand kind of physical care or kind of long-term care versus healthcare, it makes it clear that not all of the differences are cultural. So some of the preferences that we think of as being cultural might actually be shaped by what's available. So people often express preferences that reflect the options that are available for them, and if the options change, so if it becomes now very common for Indonesians to have access to healthcare that they don't have to pay for because they have their health insurance, then I think increasingly the idea that healthcare is a family responsibility will go away. So this kind of cultural preferences will change in response to the available options, the available alternatives, and I think that's sort of shown quite nicely in this graph. So this graph is based on data from the World Values Survey that kind of asks lots of kind of normative data on all kinds of different topics from countries across the whole world. So here the question that people were asked is, adult children have the duty to take care of parents. Do you strongly agree, slightly agree, up to strongly disagree with this statement? And the countries that are on the left-hand side, so Egypt, Bangladesh, Myanmar, Jordan, Iraq, they strongly agree with this statement. And the people on the right-hand side, New Zealand, Australia, Japan, Germany, United States, they strongly disagree with this statement. They don't think that adult children have a duty to take care of parents. So on the one hand, I think this captures some cultural differences, But it's interesting that even on the right-hand side, there are some countries that are Asian countries, so they're not all kind of Western countries. There's also Japan, for example, up there. And so it's maybe not surprising that Germany and Japan disagree with this statement, because they have a very strong state provision for long-term care. They have a kind of a long-term care insurance that people pay into, and that means that when they need care in later life, they can get it for free. They don't have to pay for it, and they have good home care services and residential care. So the provision is good, and so that maybe supports people in saying, okay, it shouldn't be the family. And then when you compare, say, Indonesia with Hong Kong, so culturally they may be quite similar, but in Hong Kong, because Hong Kong has invested quite strongly in kind of home care, community care services, home care services where caregivers go into the homes of older people. So people are getting used to the fact that there is an alternative to family. And so although the cultural value might still be quite strongly that the family has a role in caregiving, it's no longer this kind of strong agreement, because people in Hong Kong are maybe more aware now that there are alternatives. It doesn't have to always be the family who's doing this. So I think this shows quite nicely how cultural preferences surely exist, but they're also shaped by what's available in terms of alternatives for people. Okay, so before I go on, let me kind of clarify, because I'm focusing on cross-cultural perspectives. I need to kind of explain what I mean by culture, and it's obviously a huge concept. There's a lot of scholarship about the meaning of culture. Here I'm just going to use quite a kind of pragmatic, practical definition. So I would say that culture is a historically transmitted, so something that lasts over long periods of time, and socially shared system of meanings, values, and practices through which people interpret, experience, and organize social life. So I think the important element about culture is that they don't change from one day to another. Culture changes relatively slowly. It changes for sure, but it changes slowly. It has to be shared. You can't have, every person can't have their own culture. You have to, culture has to be something that is to some extent shared, even if people kind of disagree about some of the details. And it has to do both with values, but also with practices, what people do. So it's not just about what people think, but also what people do, and how they organize social life and social relationships, but also how they make sense of their experiences. So I would say that culture shapes ideas about who counts as family, or what's the meaning of dependence, or what kind of care is acceptable, or what kind of care is not acceptable to an older person. So I hope that makes sense. So culture is not fixed. I think that's important. It's also important to realize that culture isn't homogeneous. So I would really invite you to kind of think of cultural differences, not just in terms of East versus West, so England versus Indonesia, but also within Indonesia, you obviously have a lot of cultural difference. The Minangkabau have a different culture from the Balinese and from the Javanese. But I would invite you to even go further than that and think of subcultures even within Malang or even within East Java. So if you were doing a study just amongst your colleagues and friends at the University of Brawijaya, they will have a lot in common. They will have a kind of culture that is of highly educated people, so the views and the values and the practices and the ways of dressing and the way of talking amongst people at Brawijaya University will be different from, say, I don't know, unemployed young people who've dropped out of school and hang around on street corners in Malang. And again, will be different from your relatively uneducated agricultural farmers in some upland village that's quite remote on the slopes of Gunung Kawi. So you might all have Javanese culture as your kind of shared culture, but within that there'll be really important subcultures, and I think those are important to bear in mind. So you can do cross-cultural comparisons even if you're just studying the Javanese in Malang, I suppose is what I want to say to you. And then it's always important never to think of culture as somehow being a kind of causal mechanism. Because of my culture, I do this. It's never as straightforward as that. There's also always the kind of the resources and the constraints and so on that matter, not just culture. Culture isn't some kind of injection that you give people and then they kind of behave in one way or another. So why do I think cross-cultural perspectives matter or are interesting? I think that they are empirically enriching. So they're just fascinating in their own right, to understand that there's different ways of doing family or of providing care or of explaining the origins of disease, or the role of family versus state. I think it's just very, very interesting to see, and also by understanding that there are different ways of doing things, you can then learn from that, and you can sort of say, oh, okay, in this community, using CADA to do home visits, that really worked. People did accept that kind of intervention. So now let's try and do it somewhere else. I also think that it's theoretically illuminating to do cross-cultural research, because it allows us to kind of disentangle what aspects of social life are due to cultural values, individual preferences, structural constraints, or policy contexts. So it kind of allows us to understand where is something close to a sort of universal norm, and where is it kind of specific to a particular setting or circumstance. And then I think it also has kind of practical and policy reasons to do this kind of cross-cultural perspective, because if we pay attention to people's cultural preferences, particularly around aging and care and medical treatment, only then can we kind of adapt what we do in a way to make it kind of acceptable to the people. So if we kind of provide something that's kind of opposed to people's cultural values, then they won't accept it. But if you kind of make it saswai with their preferences, then it makes it a lot more acceptable. So for example, in England, you often have residential care homes that are targeted at particular ethnic groups within England. So you might have a care home just for Indian people, and then the food will be Indian food, and the caregivers might be Indian caregivers as opposed to English caregivers, so that you can have the language and the diet and the music and the way of interacting, and that is then much more easy to persuade an older person that residential care might be the right thing for them, than if they had to go into a care home where everybody else is white and they're the only Indian person and no one speaks their language. So it's kind of important from that point of view. And just to come back to the sort of conversation we had earlier, where kind of maybe our medical understanding is different from people's cultural understanding. If we don't get that cultural understanding first, start to kind of use information campaigns to maybe challenge some of the kind of wrong ideas that people have about treatment, for example. So you need to kind of first of all understand it, and then you can try and address it. So in order to facilitate or enable cross-cultural approaches in research, social scientists, starting with anthropologists more than 100 years ago, maybe 200 years ago, they developed the so-called comparative method. So the comparative method is a sort of systematic way of comparing two or more cases. So that could be different ethnic groups or different institutions or different communities. And the idea is that because it's quite difficult to set up experiments in social life, by kind of comparing different groups, we can maybe try and understand some of the kind of causal mechanisms and reasons for certain behaviors by studying them comparatively. So the key ingredients of comparative cross-cultural research is that you try as much as possible to use the same or at least very, very similar research questions and interview guides. Say if you're doing a qualitative interview study, then you would use the same interview guide, maybe just changing the language and some of the concepts to make them more appropriate to the different settings. But try and kind of keep the research design and the selection criteria and the length of field work and the interview guides, keep them kind of the same, so that you're collecting data which you can then compare between the Minangkabau village in Sumatra with the Javanese village in East Java. And the key thing is to also then collect as much contextual information as possible. So try to not just collect the actual data that you're interested in, but also try and understand the setting. So what's the healthcare infrastructure? What's the leadership in that community like? What religion do people have? So you're sort of trying to understand contextual information about your different cases that you're then trying to compare. So in terms of comparative research that I myself have done in Indonesia, I've been involved in sort of 3 projects. The first was my PhD research back. It started in 1999, and then I had a couple of postdocs that allowed me to kind of go back and collect some more data. But basically, that first project was just called very generally Aging in Indonesia, and try to understand older people's support networks in Sumatra, East Java and West Java. Then more recently, there was a project led by a team from Australia, but I was involved in that, and that was trying to understand social, economic and health vulnerabilities across the whole life course. So that collected data not just from older people, but also children, youth, adolescents, people at the stage of family formation, so when they were getting married and first setting up families, middle-aged people and older people. And in this research, we particularly collected life histories, but also did participant observation and some surveys. And then most recently, I led a large project on older people's care networks, where the focus was very much on older people who needed care, different types of care, and then to try and understand the kind of networks of family carers, but also healthcare professionals and village leaders around them, and understanding the care that they receive. And so, although there are different projects, the basic methodology was always the same: to use comparative ethnographic research, working with Indonesian anthropologists and some of the field work I did myself, and kind of really trying to do participant observation by staying for a long period in the study community, but also doing semi-structured interviews and also stakeholder interviews with local leaders, and then also always at the end of the fieldwork period to also design a household survey to collect data on household economy, for example, and healthcare use, and so to collect also some quantitative data at the end. So this just shows the 5 field sites in the most recent project. West Sumatra, Jakarta, Yogyakarta, Malang, and Alor. Those were the sites involved. And the reason we selected these sites was always to try and capture interesting and important cultural and other differences. So the Minangkabau community was selected because we wanted a matrilineal system where daughters are really central to older people's lives, and where there's also a lot of outmigration by sons and husbands who go on rantau and then maybe only return home occasionally. Then in urban Jakarta, we had a sort of multi-ethnic, very, very crowded site, quite a poor, very crowded neighborhood in North Jakarta, where the ties to the place of origin, because most people had migrated there during their lives, but the ties to the places of origin were no longer very strong, and because of that, the household, the immediate household, became the most important source of support and care, but also because the younger generation had to work from morning till evening. The husband or the wife was a really important source of care and support, more so than the children. Then the 2 field sites on Java, Yogyakarta, and Malang was to capture a sort of nuclear or bilateral family system where there's expectations of support both from sons and daughters, but at the same time quite a lot of emphasis on independence and relatively weak expectations of support from people beyond your nuclear family, so nephews, nieces, maybe not immediately so important. And then finally, Alor was a fascinating field site because obviously a lot poorer, and in terms of the kind of health infrastructure and roads and everything much less well developed, and a patrilineal Christian community where the emphasis was much more on sons and daughters-in-law as being the main source of care. But because there were so limited opportunities on Alor, again, you have a lot of outmigration of the younger generation and grandchildren being left behind to be cared for by the older generation, but then maybe over time the grandchildren would become a bit like children for the older generation and be providing care. So that's just to sort of show some of the diversity that we were interested in. So let me just very briefly, in terms of kind of 2 types of insights that were gained through this research, just give you two quick examples. So the first that was very much from my first project in Indonesia was an understanding of intergenerational flows of support. So in this first project, we were interested in the flows of support from older parents to their children and grandchildren, but also, of course, the support flowing from children and grandchildren to the older person. So we collected data on who does what kind of tasks in the household, who pays for daily expenses, but also in recent years, what kind of large transfers of money or land or help with housing or payment for some kind of ritual or hospitaling. So we were interested both in the kind of daily division of labor, but also big transfers of support that had happened between parents and children. And then on the basis of that, we then categorized older people into these different categories. So some older people, they are shown here in blue, are older people who are providing more support to the younger generation than they are receiving support from the younger generation. So sort of downward flows of intergenerational support. Then the turquoise is balanced flows. So maybe the older generation pays for everything because they have a pension, but the younger generation runs the household, does the cooking, and so on. So that's or it could also be a situation where the two generations are very largely independent. So the older generation does their thing and the younger generation does their thing, and there's not much going either way. And then the orange is where the more support is flowing from the younger generation to the older generation. And then the residual category is for people who don't have any intergenerational flows of support at all. And what was interesting there was how strong the differences between the Javanese village and the matrilineal Minangkabau village in West Sumatra was. So sorry, let me just go to my notes. So in Pakistan, I found that many older people were still giving support to their children or grandchildren, or they were kind of maintaining balanced arrangements or being very independent. And that fitted with the kind of cultural value of independence. So in the interviews and in my observation of family life in Pakistan, I always found that older people really like to emphasize their independence. And you could have like a 90-year-old woman living with her children, where the children was kind of really taking care of her, paying for her healthcare, making food for her, but she would still be kind of sweeping the yard or emphasizing to me, oh, I still help in the kitchen. So in the East Javanese case, people were really not keen on the idea of being dependent. And you can see only 16% of the older people were in a situation where they were receiving more support than they were giving. And they tended to be the ones who really needed the support because their health was very poor or they were very, very elderly. But most people still tried to be active, tried to provide support, or tried to maintain their independence. In contrast, in West Sumatra, it was completely different. So in the Minangkabau village, a lot of older people were really proud of the fact, no, I don't have to go and work anymore. I don't have to cook. I don't have to do this. My children now do this. And so being dependent was actually a marker of status and respect. And it showed that you'd been successful in raising your children well. And now you were allowed to kind of retire on them. So the expectation was that the cultural expectation was that the support flows should be from the young to the old, and the reality was similar. So the two kind of matched up. So in terms of kind of cross-cultural understanding, I think this case is interesting because it shows that we can't assume that dependence means the same thing in different groups or different communities. So dependence can be, as in Sumatra, the well-deserved reward for raising your children well, or it can be a really shameful experience that people in the Javanese village were really trying to avoid by kind of emphasizing that they were still doing something useful and contributing something. So, and then kind of in terms of practical implications, it shows that if you have a culture that really values dependence on children, that can also then disempower the older person. So even if the older person is still really healthy in West Sumatra, they might be made really quite passive by the insistence of the children. No, we'll do everything for you. And so sometimes that can be quite disempowering and might prevent active aging and social participation. But at the same time, if you have this kind of strong emphasis on independence and that you must avoid dependence at all costs, it can mean that people maybe hide the need for support and care that they have. So I'll never forget in Yogyakarta, we had this participant who had a daughter, but the daughter was away in Malaysia, and this woman could only get around the house by leaning on a chair. She had this little plastic chair that she was kind of using to get around the house. And she had to get water out of the well, and she had to cook for herself. And she sort of presented herself as being independent and not needing any care or support, but actually she would have benefited from having more care. So her independence was really a bit exaggerated, and she would have been better off if she'd been able to admit to needing support and having that kind of support available for her. Yeah, so I can sort of skip over that. Sorry, I should have moved on. I think so dependence can either be a positive thing, or it can be experienced as shameful and threatening to a person's status. So it's important to understand the people we're studying or treating, which side are they leaning towards? Are they quite happy with their dependence, or is this something that's quite damaging to them? And then the other example, I'll quickly skip over it because I'm nowhere short of time, was kind of what happens if the older person doesn't have children. What are the solutions available to childless older people? So the reason I became interested in this is because the community in Pakisaji had very high levels of childlessness in old age. So older people who'd maybe never succeeded in having children, or they had children but the children had died. So a quarter of the older people I studied in 2000 in Java were childless, and quite a lot only had 1 or 2 children. So family sizes were actually relatively small, whereas in Sumatra, childlessness was much rarer, and most people had several children available to them. So then I was sort of interested. So what happens if you don't have children? Who can you turn to in a culture or in a country where the state isn't providing any care and support to the older generation? What happens if you don't have a child? And there it was interesting to see that in the Minangkabau system, automatically, if you don't have children, then your sister's children are like children for you. So they will take care of you. So the kinship system provides the solution for childlessness. You don't even really have to do anything much as the older person to get that kind of support. It's sort of embedded in the kinship system. Whereas in Java, where people are part of kind of bilateral networks of kinship, having a nephew or a niece didn't automatically mean that they would care for you. They might bring you a bit of money or give you the occasional plate full of food, but they wouldn't really feel responsible to for an older childless person, and they wouldn't care for them necessarily. So in that situation, what older people had to do was kind of create these special relationships with a particular nephew or a particular niece, and make them into an anak angkat by kind of raising them and looking after them and paying for their marriage or paying for their education, and so kind of creating a special tie through this long-term investment. But this was a much more kind of vulnerable strategy because it didn't always work out. Sometimes an older person would think, oh, this is my child, this is my anak angkat, I raised them. But then when it came to the crunch, the anak angkat went back to their biological family and didn't really feel responsible for the older person. And of course, the older people who were very poor and had always been very poor, they also found it much more difficult to get an anak angkat in the first place, because who wants to give a child to someone who is very poor? So they were then in this sort of double precarious position of being economically poor, but also demographically poor, not having anybody that they could turn to. Okay, so I hope I've given you a bit of a flavor of the kinds of insights that you can gain from taking a cross-cultural approach, and how it allows you to go beyond sort of very general statements like the family provides care, to understanding which family member, is it daughters or is it sons, and for what kind of task. So when it comes to maybe money or material support, then a lot of people might be helping you. But when it comes to physical care, it's often much more narrowly defined who is allowed to do that. So the alternatives are much more limited. So I think that by taking these cross-cultural comparisons, we can also avoid certain misinterpretations or misunderstandings. So we can get away from the idea that all societies are the same, and things like dependence or family or care always means the same thing in different settings and in different cultures. But equally, by taking a sort of cross-cultural comparative approach, we can also begin to understand that not everything is down to culture. So culture might explain what some of the preferences are, but then you also have to understand the structures that people live in, the availability of certain family members, whether they're poor or whether they're rich, or whether there are alternatives available to them. So it gives an important analytical place to culture, but it also says culture isn't everything. Okay, thank you very much.
Thank you very much, Eli.
So I've put there the QR code where you can find some of the resources. We also made some films from this research, so you can all find that at that website. Let me stop sharing.
Amazing.
And sorry for going over time a bit.
Never mind. Amazing lecture, because I just realized that the culture in Minangkabau is quite different, and you investigate a lot and new information for me as well. Well, okay, so maybe we have another discussion for the
Yeah,
second
people have
lecture.
questions.
Yeah, maybe some few questions. Okay, there is a few. There's one question actually from the first lecture. Okay, we can still discuss it from Bu Sinta. So, how can researcher avoid the Hawthorne effect when conducting observation or participant interviews?
So it's really by conducting so the only way you can really reduce it is by trying to be in the kind of study situation or study context for a longer period of time, so that people kind of forget about you. That's why kind of ethnographic fieldwork is often so valuable, because people forget about it. But you can also kind of contribute to it by kind of trying to fit in. So in terms of how you speak, what you wear, so that people again forget about you more quickly. So when I started in Malang, a lot of people had never seen a kind of white person before, so they kept saying, "Oh, it's seperti di TV." So of course, at the beginning, it was kind of impossible to avoid the Hawthorne effect. But then, by staying there for a whole year, at least in the village that I was studying, people were used to me and said, "Oh, hello, Ellie," and it was no longer a big thing when they saw me arrive.
Okay. So yeah, unavoidable one, but yeah, not something that cannot be overcome, ya Bu Eli ya.
Yeah.
Do we have any questions for yes, the second lecture is very interesting because I mean, different culture, something that maybe we think it's a burden, but in the other side, it's the properties that really belong to when you're studying about human.
Yeah, exactly. Yeah.
Okay, so maybe Dr. Thomas, you want to ask something?
Good afternoon, Dr.
Okay, please, Dr. Thomas.
Good afternoon, Bu Eli. Good
Hello.
afternoon, Dr. Adi. So, Ibu, I'm planning to do a research also in qualitative study, Ibu. But I was a little bit hesitant because I'm not from Java Island, so I do not speak Javanese at all. But after seeing you, you already done that from 1999, and then the not only the language barrier, but also the cultural barrier. So, is it really a big obstacle, Ibu, when we do not speak the same language? And is it okay if we use like a translator or a device to translate in the middle of the interview, Ibu? Thank you, Ibu.
Yeah, okay. I would say it is a barrier. So for example, when I started, I already spoke some Indonesian, and then my Indonesian got better. So especially with the young people, I could communicate quite easily. But a lot of the older people, I would start the interview in Bahasa Indonesia, and they would give me really, really short answers. And then my assistant would start talking to them in Javanese, and suddenly they were kind of talking. So I think if you want to collect rich data, then it's better to use the language that you can. So, I mean, why can't you use? Can you use Bahasa Indonesia for your study?
Yes, Ibu, but we do know that like elderly like barely talk even Indonesia. They talk Japanese only.
Yeah. So then I think probably I think then probably it's best to take an assistant with you, someone, a friend or someone who is willing to ask the questions in Javanese. And then it's really important that you use a recording device, so record the interview, but ask your assistant to at least briefly summarize. Either you really train your assistant or your friend really well to know what probing questions, what follow-up questions to ask. So with my assistants, after a while, they understood what I was interested in. So they didn't have to translate the answer to me. And then I would say, now ask this. They would kind of know what to ask. But if that's not the case, then ask your assistant to give a brief translation of what the person said, and then say, okay, now ask them this, or now ask them that. But I think using a sort of translation device will be very disruptive. I think people will feel uncomfortable with that. So I think that's what I would do. You use someone to help you with the data collection, or study. I mean, you could study older people. I mean, some of the older people that you could potentially study are presumably quite hafaled with Bahasa Indonesia. If they're more educated, then they might be. So it's either you adjust your selection criteria to find people who speak Indonesian, or I would say use an assistant.
Yeah, well, I think it's quite clear, but I think currently gerontology study also involving the caregiver study. Maybe caregiver is someone who can also be involved in the study, yeah.
Yeah, totally. Yeah. So you could just make your study about, I don't know, experiences of giving care or some of the challenges of caregiving. And then the younger generation is probably more happy with using Bahasa Indonesia. What I find fascinating, just for I've recently one of my anthropologists has been doing some follow-up interviews, and now I'm using AI for transcription. And even if it's Javanese, the transcription is really very, very good. So that takes a lot of pain out of qualitative research, because when I started, I used to do an interview for 1 hour, and then I would spend 3 or 4 hours in the evening writing detailed notes or transcribing it. And nowadays it's much easier. But just make sure that if you do your consent forms and your information sheet, that you explain to people that you're going to use AI for transcription.
Okay, thank you, Bu Eli. Okay, well, maybe any other questions? Maybe 1 or 2 more questions before we close our session. Yeah, okay, 1 more questions in chat box. Okay, this is from Dr. Andri. If you plan to conduct a qualitative study on long-term care in Indonesia, what key aspect of cultural adaptation should we consider during protocol development, interview guide preparation, data collection, and data analysis to ensure credible and transferable findings?
Okay. So is this for a cross-cultural study, or just in one setting?
Maybe Dr. Andri, maybe you can just show up so we can.
So I'm just trying to understand whether it's whether you're trying to do a comparison between different sites, or just one study site. So I think the key thing in terms of cultural adaptation is to try out your kind of interview guides in the sort of setting or in the population, or as close to as possible, to make sure that they understand the question. So, for example, we included some interviews for cadre, so healthcare volunteers in our study communities, and in those we included questions about dementia, and we assumed that people knew the term dementia, but even the healthcare assistants often didn't know. So then you have to kind of describe what you mean, and the trick then is, if you immediately go to words like pikun, then you're kind of almost sort of predetermining what what you mean by it. So you kind of have to then maybe describe, okay, sometimes you might see that older persons kind of become forgetful, or they might not remember words or names, or they might lose things or get lost. So you sort of describe the phenomenon, and then say what would you call that in your community. So you're not, because you're trying to understand what terminology and concepts do they use, rather than giving it to them in advance. So that's one aspect. So try out your interview guide and be prepared to change it, and don't make it too long. Break it down into several interviews if you've got lots of questions. And then when it comes to the analysis, just really try and draw as much as possible on your understanding of the kind of cultural context. So maybe read some books, if it's Javanese, read some books about, I don't know, Javanese culture, or to try and make sense of what people told you.
Well, hopefully can answer Dr. Yandri question. So if do we have any other questions? Maybe one more questions. Okay. So if there is no more questions, maybe I will try to sum up of several points from what Bu Eli have explained to us. Bu Eli explaining there is several methods of data collection for qualitative study, and Bu Eli explain us the tips and tricks when you perform qualitative study, how to, especially in the elderly population, but I guess it also applicable to the general population. So you have to listen, you have to uh, treat them as the experts of the subjects, and then Bu Eli also introducing us one of terms that very interesting. It's the ethnographic study, that where the researchers involve or become the part of the community. And also the last talk is about the cross-cultural study, and then yeah, the barrier that can be overcome, and yeah, because this is the characteristic of the qualitative study, because we study the human more comprehensively as the subjects. So maybe that's all. Bu Eli, thank you very much for the amazing lecture. And I just realized that's a very nice batik you wear today.
Yeah.
Yeah, thank you, Bu Eli. I will return to Dr. Sri for the closing. Thank you very much.
Thank you.
Nice to
Terima
meet you, Bu
kasih.
Eli. Terima kasih
See you
banyak, Bu Eli.
soon.
Terima
Waktunya.
kasih Bu Eli untuk kuliahnya yang sangat menginspirasi kami semua. Terima kasih juga pada peserta dari luar, Dr. Estika, Bu Sinta, Ketua IPGRI Pusat, kemudian ada beberapa teman geriatri dari Palembang, Dr. Rifa dan Dr. Santi dari Manado, serta teman-teman yang lain dari dosen-dosen dan para praktisi geriatri dan praktisi lansia di Indonesia, termasuk adik-adik residen yang sampai sore ini masih bertahan. Terima kasih Bu Eli. Hopefully we meet again ya. Sometimes kita tunggu di
Pasti. Ya.
Indonesia. Makasih
Baik.
semua. Selamat
Terima
sore.
kasih banyak. Selamat
Ya,
sore.
terima kasih, Bu Eli. Have a nice day.
Thank you.
Ya,
Bye-bye.
terima kasih semuanya, Dr. Sri.
Terima kasih Dr. Adi. Terima kasih semua.
Ya, assalamualaikum.
Salam.